Hello everyone, my name is Alex Ralphie and welcome to the lecture on endocrine anatomy. We'll start with an in-depth look at the adrenal gland. The adrenal glands sit just above the kidneys and are histologically divided into the outer cortex, which sits just below the capsule, and the inner medulla. Each of these two areas, the outer cortex and the inner medulla, have very different functions. Here's the histological section from the adrenal gland. Test writers will expect you to know what the different parts of this section are and what is produced in each area. As you may recall, there are 3 different zona where different hormones are made. Are you familiar with the names of these 3 zona? The 3 zona are the zona glomerulosa, the zona fasciculata, and the zona reticularis. An easy mnemonic for this is GFR. Now way at the bottom here, we also have the medulla, which is not part of the adrenal cortex. The way I like to remember what the zones of the adrenal cortex look like on a histological section is to think about the basis of their names. The zona glomerulosa looks like glomeruli in the kidney. The zona fasciculata comes from the word fascicles, which are rods. And the zona reticularis means nets, or net-like, and you can see how these cells are intertwined. Now that we've identified the different zones, do you know what is made in each one? The zona glomerulosa secretes mineralocorticoids in response to stimulation by the circulating angiotensin II. The middle layer of the adrenal cortex is the zona fasciculata, which releases glucocorticoids and sex hormones after being stimulated by circulating adrenocorticotropic hormone, or ACTH. That same molecule, ACTH, also stimulates the zona reticularis to secrete sex hormones. A mnemonic which may help you remember these products is, the deeper you go, the sweeter it gets. This means that we start with salt or mineralocorticoids in the top layer of the zona glomerulosa, then go to sugar or glucocorticoids as you go down to the middle layer, and finally, sex hormones are produced in the deepest layer. This table lists the different layers, the hormones produced, and external stimuli for hormone synthesis. Remember that both cortisol and sex hormones are stimulated by ACTH. So how would you be tested on this? Well, you'll need to apply this to a clinical concept, so let's try it out. Let's say you have a patient with a recent history of severe meningitis, and now presents with blood pressure of 80/60 and a serum sodium of 127. So, if you've already studied microbiology, you may have an idea of what's going on here. But for those of you who haven't, let's focus on the key clinical factors. Clearly, our patient has low blood pressure. And if the sodium is low, what hormone might be deficient? Right, aldosterone. Where is aldosterone made? The adrenal gland specifically. Which part of it? The zona glomerulosa. Great. So, what does meningitis have to do with this? Well, what if I were to tell you that the cause of this patient's meningitis was due to organisms seen here on the Gram stain? As you can see, these are gram-negative diplococci. Do you know what the underlying problem is here? Some of you may have recognized this as a cause of Waterhouse-Friderichsen syndrome. And what is the cause of his meningitis? Right, Neisseria meningitidis. Waterhouse-Friderichsen syndrome is a complication of Neisseria meningitidis infection that can cause adrenal hemorrhage and hence adrenal insufficiency. When this occurs, the adrenal gland is not producing sufficient hormones. As a result, the patient is hypotensive due to a decreased production of mineralocorticoids as well as glucocorticoids, which also have some mineralocorticoid activity. Based on the case that was just described, which is written out here, what would you expect the following hormone levels to be? When faced with a question like this, try to fill in the answers yourself before looking at the answer choices. If you can't figure out everything, then just use what you know to eliminate answer choices. Take a moment to pause the video to come up with your answer, then we'll discuss the case. The answer is B. As we discussed, the adrenal gland makes aldosterone, cortisol, and DHEA, or dihydroepiandrosterone, a sex hormone. Therefore, since the gland is damaged, these will all be decreased. However, you will still have elevated ACTH. Do you remember why this is the case? because you no longer have the negative feedback of cortisol on ACTH production. Your pituitary has no idea that your adrenal gland is hemorrhaging. It only sees that the cortisol level is low, so it will try to ramp up production of ACTH to hopefully stimulate more cortisol. When considering the negative feedback concept, refer to the introduction and embryology lecture for review. We've talked about the 3 layers of the adrenal cortex, so now we'll move on to the innermost region of the gland, the medulla. The adrenal medulla is comprised of chromaffin cells. These are a type of neuroendocrine cell. Do you remember what innervates these cells? The adrenal glands are an oddball. They aren't innervated by the normal preganglionic or postganglionic system, specifically epinephrine and norepinephrine from the chromaffin cells. Knowing that these cells produce catecholamines such as norepinephrine and epinephrine, which are also neurotransmitters found in the CNS, may help you remember that chromaffin cells of the medulla are derived from neural crest cells. An interesting thing about the secretion of these hormones from chromaffin cells is that, in contrast to other cells of the autonomic nervous system, in which we see direct release of epi or norepi onto target cells, here epi and norepi enter the bloodstream and have a systemic effect. In other words, instead of paracrine signaling, here we have an example of endocrine signaling. The venous drainage from the adrenal gland is similar to that of the gonads. On the patient's left, the left adrenal vein drains into the left renal vein before joining the IVC, as shown here. On the right, the adrenal vein goes directly into the IVC, as shown here. To finish up our discussion of the adrenal gland, let's do a couple quiz sections to see what you remember. For our second question, what is the embryologic origins of the adrenal cortex and medulla? The outer cortex layer is derived from mesoderm, whereas the inner medulla layer comes from the neural crest cells. Remember, the medulla contains the chromaffin cells that produce norepinephrine and epinephrine. Easy points on test day. Remember the embryologic origin of these 2 layers. Since they are different, these are easily tested. Let's discuss the pituitary gland. Where is this gland located? In the sella turcica, which is a depression or saddle-shaped indentation of the sphenoid bone, shown here. The pituitary gland itself has 2 different parts. Do you remember what they are? That would be the anterior pituitary, which is also called the adenohypophysis, and the posterior pituitary, also called the neurohypophysis. The posterior pituitary is true neural tissue, basically an extension from the hypothalamus down into the sella turcica. Meanwhile, the anterior pituitary is a separate type of tissue. Do you recall what is the origin of the anterior pituitary? The anterior pituitary arises from the invagination of oral ectoderm, termed Rathke's pouch. Another key distinction between the anterior and posterior pituitary is that the hormones released by the posterior pituitary are actually synthesized in the hypothalamus and transported via chaperone proteins, called neurophysins, to the posterior pituitary where they are released. This is sometimes referred to as magnocellular secretion. Contrast this with the anterior pituitary, which produces its hormones in response to the release of molecules from the hypothalamus, which we will discuss in a moment. First, we will talk about the posterior pituitary. Can you tell me what hormones are made there? This is a trick question. None of them are made there. Remember, they are transported from the hypothalamus. So what are the hormones that are released from the posterior pituitary? Vasopressin, aka ADH or antidiuretic hormone, and oxytocin. Do you recall what vasopressin's main function is? Vasopressin acts directly on the kidney to increase water absorption. Now, how does the brain know when the body needs more water? Well, pay attention, because this is very unusual. The pituitary is one of the few regions where the blood-brain barrier is absent. So how does the absence of the blood-brain barrier matter in this case? Well, without the blood-brain barrier, you can sense changes in plasma osmolarity. This will stimulate the release of vasopressin when the osmolarity gets too high. You'll learn more about this in the renal lectures, but a key thing to remember is that the production of ADH is primarily driven by changes in serum osmolarity. This means that ADH has less of an impact on maintaining volume status, such as low blood pressure, which is really covered by aldosterone for the most part. Now, what are the two main functions of oxytocin? This is a key hormone associated with pregnancy, as it is involved in milk letdown, and it also stimulates uterine contractions during labor. Now let's talk about the anterior pituitary, also known as the adenohypophysis. There are 6 hormones produced and secreted by the anterior pituitary, and they can be memorized with the mnemonic flat pig. We have FSH and LH, which are involved in reproduction, ACTH, which primarily acts on the adrenal gland to stimulate the production of cortisol and androgens, or sex hormones, TSH, which acts on the thyroid, prolactin, which is involved in milk production, and growth hormone, which has a wide range of effects on metabolism and growth. You must also remember what molecules are produced in the hypothalamus which stimulate the release of these anterior pituitary hormones. Most of these molecules act as positive feedback to increase the release of the hormones in the anterior pituitary. These include gonadotropin-releasing hormone, corticotropin-releasing hormone, thyrotropin-releasing hormone, and growth hormone-releasing hormone. However, there is one outlier here. The release of prolactin is controlled via inhibition by a specific neurotransmitter. Do you remember which one? Yeah, it's dopamine. One commonly tested concept involves how to differentiate these hormones from each other biochemically. TSH, LH, FSH, and human chorionic gonadotropin, or HCG, all have an alpha subunit in common. However, each of these have a unique beta subunit, and it is this second piece that determines their specificity. Finally, the anterior pituitary is made up of 2 different cell types that produce hormones, and they are classified based on their histological staining properties. The first group are the acidophils, which stain red and produce GH and prolactin. The second group are your basophils, which stain blue, and these produce FSH, LH, ACTH, and TSH. Endocrinology is a section full of mnemonics, so we've got another one to help you remember this. You can remember your blue basophils with B flat, and you can remember your red acidophils with a mnemonic GPA. Either way, as long as you know one, you can't miss the other. So here's a question for you to see what you remember from a couple minutes ago. What would be the side effect of a drug that blocks dopamine release? Galactorrhea, which is milk being released from the breast. Now this can cause quite a shock to people not expecting it. This occurs because you no longer have dopamine to inhibit the release of prolactin. And remember that we just talked about how prolactin is responsible for milk production. Another cause of galactorrhea is a prolactin-secreting tumor. In fact, this is the most common type of functional pituitary adenoma. This type of tumor will be reviewed again in later lectures, so keep it in the back of your mind for now. Now we'll move on to the pancreas and discuss its role in the endocrine system. Remember that the pancreas is unique in the sense that it can function as an endocrine gland by releasing hormones into the bloodstream, as well as an exocrine gland by releasing digestive enzymes directly into the GI tract. You'll hear about this more with regards to the exocrine functions in the GI lectures. This is the histological section of the pancreas, and throughout the pancreas are small islands of hormone-producing cells, known as islets of Langerhans. They are most numerous in the tail of the pancreas, and they are composed of 3 major cell types, which you'll need to be familiar with for your exam. As we discuss the cells that make up the islets of Langerhans, I will go in order of prevalence, starting with the beta cells. These account for almost 70% of islet cells and are responsible for producing insulin. These cells are found centrally within the islets. The way I remember this is insulin is produced inside the islets. Insulin is produced inside the islets. The next most prevalent cell type are alpha cells, which produce glucagon, which are located peripherally. Finally, we have delta cells that produce somatostatin and are interspersed throughout the islet. Here is a cartoon that more clearly depicts the locations of these three different cell types. That wasn't so bad, was it? In the next section, we'll cover endocrine physiology, which I'm sure you'll find incredibly interesting.